Constraint-induced movement therapy, or CI therapy for short, is one of the most effective rehabilitation programs for treating arm weakness resulting from stroke, multiple sclerosis, cerebral palsy, and/or traumatic brain injury. CI therapy is more effective than standard care because it changes a person's habit of not using the weaker arm to perform daily activities and relying almost exclusively on the stronger arm. Because it promotes habit change, CI therapy gains are well maintained over time. It is also the only therapy that has been shown to change brain structure and function. The therapy was developed by behavioral neuroscientist Dr. Edward Taub, following tens of years of human and animal research. Its effectiveness has been shown in hundreds of research studies. This video will explain the components of CI therapy and the research behind each component. It will also describe how family members can aid in the recovery process. This video is an important resource for both patients and their families because a thorough understanding of the intervention has been shown to enhance outcomes, and strong family support has also been shown to aid in the recovery process. The goal of CI therapy is to intensively train the weaker arm while discouraging use of the stronger arm over a 2 to 3 week period. CI therapy targets not just motor improvement, but also daily use of the weaker arm to retrain neurological pathways in the brain. Immediately following a stroke or brain injury, the brain is in a state of shock. Due to inflammation and disruptions in brain signaling, a person typically has the most difficulty with cognitive and motor functions immediately after the stroke. When motor functioning is affected, the person attempts to move the weaker arm repeatedly without success. Unconscious learning quickly takes place that the weaker arm is no longer useful. The stronger arm begins to take over all tasks. The weaker arm is used less and less. Over the first weeks to months, some arm function returns, but the person has already formed a habit of not using the weaker arm. With less use, the weaker arm becomes progressively weaker, maintaining the cycle of non-use. Continually neglecting the weaker arm also rewires the brain in a negative way. As connections between the brain and weaker arm are less frequently used, brain signals to the weaker arm begin to weaken, leading to weaker and less precise movements of the more affected arm. For sustained recovery to happen, this damaging cycle needs to be broken. Standard therapy does not typically provide enough repetition to substantially strengthen the weaker arm, and there's no emphasis on changing a person's habit of not using the weaker arm. If this habit is not changed, any recovery that happens is unlikely to be sustained well over time. CI therapy is different because it provides intensive training to strengthen the affected arm, paired with several strategies to increase use for daily activities. Though the extent of motor practice required to maximally strengthen an affected arm is still unknown, CI therapy uses an intense dose of active motor practice. Repetitive and intensive physical therapy is implemented for approximately 30 hours over a 2 to 3 week period. This amount of training seems sufficient to substantially improve motor strength and function. Studies using higher doses, up to 6 hours of training per day, have shown no added benefit from the additional training. Take-home point: 30 hours of focused training over the course of 2 to 3 weeks seems to be enough, but it may even be more than what is needed. This training, though, is not sufficient to break the damaging cycle of non-use and weakening brain connections. If the habit of non-use is not changed, motor gains during training are less likely to be maintained over time. CI therapy counters non-use by encouraging the person to exclusively use the affected arm for the majority of daily activities. Using the weaker arm more than the stronger arm will reverse the process of weakening brain connections and begin a process of adaptive rewiring. A study by Liepert, Taub, and colleagues, published in 2006, shows this adaptive plasticity in action. Before CI therapy, the region of the brain that controlled movement of the weaker hand was smaller than the region of the brain that controlled the stronger hand. Following CI therapy,
there was a large expansion in the area of the brain that controlled movement of the weaker hand. CI therapy also increased the volume of parts of the brain that are involved in voluntary movement.
In order for this adaptive plasticity to occur, a person needs to change the habit of not using the weaker arm. When I was a grad student with Ed Tao, we compared two different treatments. One group of participants received the full CI therapy intervention, and the other group of participants received intensive training only in the clinic.
The group that received the carryover techniques of CI therapy showed 3 times the improvement in arm use for daily activities compared to the intensive training group. Only the CI therapy group showed structural brain change. The only difference between the groups was that the CI therapy group also received techniques designed to increase use of the weaker arm for daily activities. So this brain change can most likely be linked to doing more daily activities with the weaker arm. The more that people used their weaker arm for daily activities, the greater the brain change. Additionally, quality of life increased only for participants who used their arm significantly more for daily activities, but not for those who did not use their arm more after the intervention. Improvement in quality of life was much more strongly related to increased arm use than to improvements in movement ability.